categories. Sorry, Anna, can you go back to the slides? I think there's 4 different categories. So if you've undertaken any quality improvement work within the last year, I believe it's the within the last fiscal year, accepted or published, please do submit it. There's always a lovely lunch in the spring for the winners. Great, yeah, there's the 4 categories. So first, authored by a trainee, best publication for an adult population, best for a pediatric population, and then publications focused on healthcare professionals. So the 4 categories there. The next announcement, Anna, do you want to just take it out of presenter mode? Okay. In the Stanford, the Quality Symposium is going to be May 5th this year. There'll be an abstract call sometime in the new year in the spring, so please look out for that, and please save the date to consider joining us for a presentation of quality improvement work that's going on within Stanford. And I think was there one more announcement?
That's it.
Okay. Okay, great. Thank you all. Well, great. So on to our presentation today. So we have 2 speakers today, Drs. Neil Kulwani and Samantha Kling. Dr. Kulwani is the Director of Preventive Cardiology at the VA Palo Alto Healthcare System and a clinical instructor in the Division of Cardiovascular Medicine at Stanford. His research focuses on the implementation and evaluation of innovations in care delivery designed to improve the value of care for people living with cardiovascular disease. And Dr. Kling is, of course, our quantitative research scientist in the Evaluation Sciences Unit. She has expertise in mixed methods research and evaluation and implementation science. Today's presentation is really illustrative of her and the ESU's collaborative work with clinicians to design and implement pragmatic evaluations using implementation science approaches to evaluate healthcare innovations. If you have any questions, please feel free to put them in the chat, and either Dr. Kling or Dr. Kulwani would try to answer as we go along, but otherwise we will save them for discussion at the end, and we will try to wrap up about 10 minutes before the hour as we usually do. So I will hand over to Drs. Kulwani and Kling. Please take us away.
Can you all see the slides there?
Yes.
Okay, perfect. All right, well, thank you so much for the opportunity to present today, and very excited to talk to you about our paper that was published and on this topic of EHR alerts to promote adoption of limited echocardiograms in outpatient clinics. And this was an evaluation of a value-based care initiative that was introduced at Stanford Health Care. And I'm very excited to be presenting with my co-first author on our paper, Samantha Kling. All right. So just to give a little bit of background to start us off, so cardiac diagnostic imaging is a significant driver of rising healthcare costs in the United States. And just for background, so an echocardiogram, which is the test that we're going to be talking about today, is simply an ultrasound of the heart. It's the most common cardiac imaging test, often the first test that's obtained when heart disease may be suspected. And it is a significant source of Medicare spending, at least, $900 million in 2019, and that number is certainly likely increased since then. The most common form of an echocardiogram is a full or a complete echocardiogram, which is really a comprehensive evaluation of all aspects of cardiac function, and can take up to an hour for a technician, an ultrasound technician, to complete, including the measurements that are done after the images are acquired. And then a physician, typically a cardiologist, would read the ultrasound after it's been completed. There is an alternative test, which is a limited echocardiogram. And this test examines a single area of the heart or answers a single clinical question. For example, assessing just the left ventricular systolic function, which is the pumping function of the left side of the heart, for example. And the use of this limited test is supported by clinical practice guidelines, specifically for follow-up of known cardiovascular conditions. So if you know that there's a specific issue that's abnormal or requires monitoring, a limited echo is appropriate to follow that up in subsequent tests. Limited echocardiograms take less time to complete than a full echocardiogram, and as a result, they're associated with lower costs, both in terms of the health system cost to produce the test, And also the insurance reimbursement that the health system would receive is lower. There's a different CPT code for a limited echo as compared to a full echocardiogram. In spite of these factors, the use of limited echoes actually remains quite low in clinical practice, and we'll get into some of the reasons for why this is later in the presentation. So just to give a clinical scenario when a limited echocardiogram would be appropriate, if we have a patient, this is Miss Jones, she presents to her doctor with shortness of breath and signs of fluid retention on exam. And the initial test that's ordered is a full echocardiogram, which reveals that Miss Jones has reduced pumping function of the left side of the heart, or reduced systolic function, which is measured as an ejection fraction, which is the proportion of blood that's pumped out with each heartbeat, and that is reduced. There, importantly, are no other abnormalities identified, so the valves are working normally, the right side of the heart is working normally. And so she's diagnosed with left-sided heart failure as a result of her presentation, symptoms, and the echo results. And as a result, she's started on medications to improve her heart function and to actually improve the ejection fraction at the time of this diagnosis. And then 3 months later, the physician following her appropriately wants to reassess her heart function to see if there's been any improvement in the pumping function of the left side of the heart. And so a limited echocardiogram instead of a full echocardiogram is ordered at that time, since the clinical question is narrowly focused on whether the left-sided pumping function has improved over these 3 months. And so this would be a typical scenario when a limited echo would be appropriate. And so just to give a little background on the intervention, so this cardiac imaging sprint project was actually part of the early value-based care program that was sponsored at Stanford Health Care to address rising costs in the Stanford Health Care Alliance insurance plan back in 2020. And this program has since evolved. Now it's the Accountable Care Program and is focused on other issues. But this was in the early days of this VBC program at Stanford Health Care. And one of the findings when the initial scoping for this program was done was that utilization of echocardiograms for this clinical population was 155% of risk-adjusted benchmark rate. So it seemed like there was potentially overutilization of echocardiograms for this population and associated elevated spending on that category of testing. So as a result, there were, in addition to other sprint projects that were defined in this period, there was a cardiac imaging sprint project, which had the specific mandate to design and implement interventions to promote value-based use of echocardiograms at Stanford Health Care. Just to introduce the team for this project, so Eleanor Levin was the lead of this project as the value-based care champion. And she's a clinical professor in cardiology at Stanford. I joined the team as a fellow at the time, as a research fellow, to support the evaluation of the interventions that were introduced. The co-lead for the project was Sandra Tsai, who's a primary care physician and preventive cardiovascular clinician who's based in primary care and population health. And then we had support from the SHC side, from the quality side, from Cindy Gaspar, who was manager of population health transformation and currently is no longer at Stanford Healthcare now, but was in that role at the time. And then on the operations side, we were supported by Mitch Gafenku, who's director of CD operations for SHC. So early in the project, there were several informal one-on-one conversations that were held with clinicians to identify barriers to limited echocardiogram use at Stanford Health Care. And several barriers were identified, including first, that there was limited knowledge of this testing option. And so many clinicians actually weren't even aware that there was a limited echo option available at Stanford Health Care. There was actually a separate order that was required for limited echocardiograms, separate from the full echo order. So clinicians needed to be familiar with the fact that a different order was needed and to place that alternative order at the time that they wanted to order the test. And then in addition to that, they had to actually remember it at the point of care, because these tests are typically ordered during clinical encounters with patients where clinicians are speaking with the patients. And so actually remembering to order that alternative test for appropriate patients during the encounter was a barrier to using this alternative test. And so this led to the development of the solution that we studied in this project, which was a limited echocardiogram alternative alert. And this is an alert that appears in the EHR in Epic when a full echocardiogram order is placed to suggest consideration of an alternative limited echo order instead in appropriate patients. And the goal of this limited echo alternative alert was to do several things. First, to educate clinicians on the existence of the alternative test. So it actually both lets them know that there is this alternative test, but also what the appropriate clinical scenarios might be to use the limited echocardiogram, which you can see listed here. It actually gives you the option to choose the limited echo test in the alert itself, so you don't have to go hunting for that separate order that you may not be familiar with. And then it appears at the point of care when the full echo order is placed, so that way it serves as a point of care reminder about the option to get the limited test instead. And just for background, you'll see TTE throughout the presentation in some of the slides. That's the full name of the echocardiogram, transthoracic echocardiogram. So you'll see that listed in some places. So just wanted to clarify that. Just to give you a sense of the workflow for when a patient presents of when the alert would fire. So if a patient showed up with an indication for an echocardiogram, if the provider just ordered the limited echo off the bat, there would be no alert. They would just place that order directly. If they, however, ordered a full echo, there was actually an EHR integrated decision tree that would use the patient's existing diagnoses in their problem list and only fire the alert if they did not have another diagnosis, for example, valvular heart disease or hypertrophic cardiomyopathy or pulmonary hypertension, other diagnoses that really necessitate a full echocardiogram. And so if they did not have any of those exclusion diagnoses, then the alert would fire, giving the option to choose the limited echo alert. And one thing to note here is that the limited echo order actually includes the option for the echo lab to convert the limited echo to a full echo if clinically indicated. And that might be if they find something on the echo that's unexpected, that requires a full echo, or if maybe the reason for the limited echo, actually additional images would be needed based on the echo tech or attending's perspective. And so they end up converting it to a full echo. And so as far as the implementation of this alert, so I think it was really made possible by dedicated support from Technology and Digital Solutions, the TDS team at Stanford Health Care, that was provided by the value-based care program. So the alert development was fast-tracked and there was dedicated IT support for building the alert provided by the health system. And this allowed the alert to be rolled out in 2 pilot clinics in July of 2020, early in the initiative's development. And then 2 more primary care clinics in January of 2021. And then the alert was rolled out to cardiology in 1 clinic in February of 2021. The alert was advertised and introduced to faculty at faculty meetings but prior to its rollout, so faculty were aware that the alert was being deployed. And then we were very lucky on the project team side to get to partner with the evaluation sciences unit starting in April of 2021 to actually implement a rigorous evaluation of the alert. And this collaboration was sponsored by the value-based care program at SHC. So now I'm going to hand things over to Sam, who's going to talk through the ESU team's role and the results of the evaluation.
Thank you, Neil. So just a brief overview of our team. The folks in red were directly involved in this project. This is a huge team effort since it was a mixed methods project with many quantitative data sources, as well as qualitative interviews conducted with physicians. But if you don't know the ESU, we are a mixed methods team of qualitative and quantitative scientists, clinicians, and Anna, who is helping us with this call today, is also our operations manager. So first of all, thank you to all these folks for helping the clinical team and myself with this project. Next slide, please. So a brief introduction about what we do as the ESU and how this was a prime example of how we take our expertise and our skills and apply it to a clinical problem. So we are really focused on embedded healthcare delivery research, such as EHR, improvement implementations. And we have 3 areas of focus: evaluation science, implementation, and quality improvement science, which this project hit all of these 3 areas. But I wanted to highlight first how this really demonstrated how implementation science can really improve the evaluation scope of a project. Next slide, please. And you can click through, Neil. Sorry about the animation. So we use mixed methods to evaluate the outcomes in this project, and I'll get into those more. But our general framework, which maybe many of you have seen before, is we really like to focus on the red implementation outcomes. And here we did that by really looking at provider perspectives as well as provider behavior in the EHR. And then I'll also talk about a service-related outcomes related to ordering of the echocardiograms in this project. Next slide, please. So what our evaluation looked like had qualitative and quantitative components. Quantitative component include the impact of the initiative, here the alert on clinicians practicing patterns. So this looked at both the clinic level ordering data, so what limited echocardiograms and what full echocardiograms were ordered, as well as clinicians' responses within the alternative alert. So did they switch their order from the full echocardiogram to a limited echocardiogram, or switch from full echocardiogram to not ordering anything at all? And then qualitatively, we talked with 19 primary care providers and 5 cardiologists to get their perspectives on this initiative. We also had frequent collaborative meetings with the operation and clinical team, and we provided real-time reporting of our findings, especially the qualitative findings, to the operations teams to inform some improvements that were made later on, which Neil will discuss. Next slide, please. So just to give you a scope of the size of our project, during implementation, the alert Neil showed was triggered 720 times. And after the alert, 99 limited echocardiograms were ordered and 561 full echocardiograms were ordered. The alerts were initiated after a small portion of full echocardiograms ordered, and across the project we had cardiology ordering over 14,000 echocardiograms, either full or limited, and primary care ordered over 1,300. Get a little more on those numbers on the next slide. But we had a total of 13 cardiologists interacting with the alert and 64 primary care providers during the intervention period. And then again, we had a great qualitative sample of 5 cardiologists and 19 primary care providers. This was conducted 6 months into the intervention. Next slide, please. So since we were brought on to this project kind of definitely post implementation, we originally had our kickoff meeting in April of 2021. And as you see by the dark gray bars, those are when the alternative alert was implemented, that we came in the midst of a project. So we adjusted our evaluation to account for these differences in start dates. So in the light gray periods, that's going to be our baseline period, which I'm going to refer to on the next slide. And then the dark gray bars are the intervention periods. So we have shown here the 4 primary care clinics in rows, I guess, 3 and 4 that received the intervention, and 1 primary care clinic that did not receive the intervention. And then for cardiology, we had 1 intervention clinic and then 3 comparator cardiology clinics. So a complex design here. Next slide, please, Neil. So our main results, we're looking at the percent of limited echocardiograms of all cardiograms, echocardiograms ordered. So the first graph on your left is looking at the cardiology clinics with the intervention clinic on the left, the control or comparator clinics on the right. We see that the percent of limited echoes ordered of all echocardiograms increased substantially in this cardiology clinic from around 6% to about 24%. Where we saw in the comparator clinics, minimal change. And then you'll see on the figure in the right, our 4 intervention clinics are shown first, and we see a huge uptick from about 1% in the baseline period of limited echocardiograms ordered, and then which increased to about 13% in the intervention period. You'll see on the last set of bars that there was a small uptake in our 1 comparator clinic. This could be spillover effects with physicians practicing at multiple clinics, or the message getting out at faculty meetings that the team was focused on promoting limited echocardiogram ordering behaviors. Next slide, please. So based on that, we saw that data and we're like, wow, this intervention is effective. But there was always more to dig into with the qualitative data. So what we found in interviews with clinicians is that the alternative alert was generally acceptable to them, but primary care providers really needed more information to feel comfortable ordering these tests. Primary care providers order these tests less frequently than cardiologists, so they wanted more information about what was in the test and some clarifications related to the text within the alert. But on the other hand, cardiologists felt like this really could integrate in their workflow and were appreciative that it reminded them of the few limited scenarios that the limited echocardiogram could be used in. Next slide, please. And one facilitator of this acceptance of the alternative alert to promote this change in ordering behavior was the option for the echo lab to be able to upgrade a limited to a full echo depending on what they found. Both cardiologists and primary care providers identified this. However, primary care providers also had the viewpoint that they felt like the full echo was just more convenient for themselves and the patient, as it provided more information and prevented the patient from potentially having to go for a follow-up visit for that full echocardiogram. Next slide, please. And just as a reminder of that first facilitator of the ability for the echo lab to switch between the limited and echo, you can see when it says below alternatives, thank you, Neil. This is the part that both cardiologists and primary care providers appreciated and reassured the clinicians that they could order echo now, but a limited echocardiogram now, but it could be switched to that full echocardiogram at the actual echocardiogram visit. And then, as I mentioned earlier, we also looked at the clinician's ordering behavior within the alternative alert. So the bar graphs were like what was ultimately ordered, but we also took a look at like how people use the alert once it popped up on their screen. So again, the alert popped up a total of 720 times. And at about 19% of those times that it popped up, clinicians did change their order from a full echo to either a limited echocardiogram or remove the order completely. Cardiology was a little less likely than primary care to switch their order, but the differences were very small. However, it did show that only at about 1 in 5 times did the alert result in a provider changing their order. So suggests maybe some improvements are needed in the ability of the alert to be targeted to the right clinical scenarios. And then I'll hand it to Neil to go through the key takeaways.
Great, thanks, Sam. So sort of summarize the results here. We found that the alert was associated with an increase in the proportion of echocardiograms ordered as limited studies in both primary care and cardiology clinics. When we interviewed clinicians, there was high acceptability of the alert, but there were key differences between the perspectives of cardiology and primary care. Cardiologists appreciated that the alert reminded them of the appropriate scenarios to order limited echoes at the point of care and made it very easy for them to incorporate in their workflow. Whereas a lot of the primary care providers felt that they didn't totally understand the limited echo role and when to order it, and they wanted more information about the limited echocardiogram test in the alert. For both providers, including the option to actually convert the limited echo to a full echo if determined necessary by the echo lab, was a significant facilitator of implementation. And interestingly, despite the differences in the perspectives, both cardiology and primary care clinicians changed their orders in response to the alert in about 1 out of 5 cases of seeing the alert. And so that was significant as well. So just to get a little bit into how these findings ended up impacting the actual intervention. So one of the key changes was that the limited echo alert was tailored into 2 separate versions for cardiology and primary care. And so here you can see the updated version for cardiology. And this version actually includes it took away some of the extra text and really focuses on providing some additional clinical scenarios when getting a limited echo would be appropriate. So with reduced pumping function, if there's a blood clot in the heart, if the aorta is dilated and you're trying to track that over time, or if there's fluid around the heart and you're tracking that. And it really used language that would be very familiar to any cardiologist. And then ultimately, because of the very positive reception from cardiology of the alert, this alert was expanded across all SHC cardiology clinics in June of 2022. For the primary care alert, the alert was actually changed in a different way to actually include more information on the appropriateness of echocardiograms in different scenarios, the appropriate use of limited studies, and then also provided some links to care pathways, which actually sort of apply to common conditions that frequently require cardiac imaging. We were able to actually publish the results of this evaluation in Circulation, Cardiovascular Quality and Outcomes, and there's a QR code to the manuscript here in case you want to read more about it. And Sam and I were very fortunate to be co-first authors on this paper, so enjoyed working together on that. And then wanted to end here before we go into questions, just with some lessons learned, key takeaways for both value-based care and then for implementation of these types of interventions. So for value-based care, I think one key finding that we had was that it really is critical to tailor these clinical decision support interventions to the clinical audience, and specifically specialists versus non-specialists. And I think that's especially critical when in situations like this one, where the specialists have a very different level of experience with the test in question as compared to non-specialists. We also, another key takeaway was that, as Sam sort of highlighted, the limited echo alert was only accepted to convert to a limited echo in about 10 to 15% of cases, which in reality is pretty low, actually. And I think this really highlights that in the future, we really need to focus on better targeting of clinical decision support tools to the appropriate patients at the right time. And I think one of the limitations of this project was we could only use data that was in the EHR prior to the existing encounter. So no current encounter data could be used to trigger the alert, only data that was there prior to the patient coming in. And so we had to use the existing problem list, but couldn't use any information from that actual encounter as part of the triggering criteria. And that was just a limitation of Epic. And in the future, I think if you could incorporate information from the current encounter, specifically through AI, for example, including the text in the clinician's note, potentially even the conversation between the clinician and the patient through the ambient scribes that are now becoming more popular. If that information could inform the alert, you could really tailor alerts to the exact right patient at the exact right time. And so I think that represents an opportunity for the future. Also, just to mention that alert fatigue is definitely real and growing. One anecdote from our current practice is this: our cardiology quality improvement team has continued working together on other projects. And for a recent project focused on heart failure, we were looking at potentially doing another alert. And the feedback we got from primary care clinicians was that there are too many alerts and there's no appetite or capacity to add more alerts at this point. And so I think that really highlights, just since 2020 to now, how much there's been an increasing volume of alerts and more alert fatigue. And I think that, again, really emphasizes that we should be designing alerts that only fire when they're very likely to be accepted and improve care. And I think all of us as clinicians have experiences where alert has helped us improve the quality of care that we provide to patients, but it's really about the targeting of the alerts that I think can address this issue of alert fatigue. And then just to end here on some lessons learned for implementers, I think this project really highlights that the intervention design really matters to enable evaluation. We were fortunate, even though we collaborated with the ESU team on the later side, we actually had designed the alert in a stepped rollout as opposed to rolling out across all clinics simultaneously. And that did allow us, with the quantitative analysis, to somewhat disentangle other factors from the actual effect of the alert itself with the evaluation design that Sam went over. Working with operational data is always messy, and I'm always reminded of that every time I do one of these projects. Looking at the EHR data, there were order classifications that we didn't know what they meant, and we had to go back and forth with the Epic team multiple times. So that's always a key reminder for me doing these sorts of projects. I think here in this project, the mixed methods approach was really essential. And I think it's taught me a lesson not to underestimate doing qualitative evaluation, because if we'd just done the quantitative evaluation, as Sam said, we would have just said, oh, this project worked, it was successful. But I think in reality here, we found a lot more nuance when we went into the qualitative data that let us make the intervention, make improvements to the intervention. And finally, I think this all highlights the importance of bringing on the evaluation team early. I think both to inform the intervention design and then to actually facilitate the evaluation to be done in parallel with the intervention itself. And so I think highlighting the awesome work that the ESU team does. So with that, I'll stop and would love to take questions and engage in a discussion with everybody. Thank you so much.
Thank you so much, Dr. Kulwani and Dr. Kling. I'm sure everybody would join me for a round of applause. I really appreciate how you took what you learned and applied it to improve the implementation and tailored the approaches for primary care and cardiology. I think that's just a really important lesson that you were able to kind of act on and improve that. So I really appreciate your sharing that. If anybody has any questions, please feel free to put them in the chat or raise your hand. And I see we have a question from Michael Rothman. So if you'd like to unmute and ask your question.
Yeah, I agree. The evaluation seems amazing in partnership. And Neil, I kind of had a question on your first lessons learned, where you showed the 10 to 15% kind of response to the alert. And when you step back to a clinical significance mindset, which I know is how you started to approach this, is that worth it?
Yeah,
in terms of?
Yeah, no, it's a great question. I think that, for the cardiologists, I think they really appreciated actually not having to go hunt for the limited echo order. And I think that if you could, I think what's the right level of acceptance for an alert to be considered successful? I think it probably matters on how annoying the alert is to click through. And so I think actually for the cardiologists, they were very comfortable saying, no, I want the full echo, and you just click that radio button. And so I think they didn't find it as disruptive. Whereas I think there's a cognitive aspect where for the primary care clinicians, a lot of them were like, what is a limited echo? Am I ordering the right test? And so I think that discomfort of not knowing which test to choose was actually much more, even though it's the same alert. And I think that highlights the difference between this alert for primary care versus cardiology. I think that cognitive challenge actually slowed the PCPs down more, and was why they found it to be challenging to not have the information they needed to address the alert. And so I think for cardiology, this was actually, I think people found it very smooth in their workflow. They knew what a limited echo was. They didn't want to have to hunt for the limited echo alert, and they did actually accept it a lot of the times. And one of the things that we saw was that a lot of the cardiologists actually started ordering the limited echoes directly. So they learned from the alert, and they actually didn't need the alert anymore because they were reminded so much about the limited echo option that they started just placing that order directly, whereas PCPs almost never place the limited echo order directly. And that to me tells me that they weren't really absorbing it into their clinical practice because of that discomfort. So I would say for cardiology, maybe a 20% acceptance rate would be appropriate if it wasn't felt to be too disruptive. But for primary care, maybe because of that cognitive dissonance, it actually was counterproductive and slowing them down too much. So I think maybe a higher hit rate for primary care would be needed to really make it worthwhile.
So Dr. Kolwani, I have a question, and you kind of touched on it towards the end, but how would AI change this now? What are the opportunities for AI in improving the sort of EHR environment, potentially reduce alert fatigue, fire more appropriately in clinical scenarios? Like, what do you see as kind of the potential of AI for this?
Yeah, I think so. On the SHC side, now we have, and I think also on the LPCH side as well, there's, we have ambient scribes now that are actually listening to our visits and generating note summaries. We now have, in Epic, this chat EHR chatter, which is actually doing LLM search of the entire medical record now, similar to like a chat GPT in Epic. And so I think in the future, I imagine there'll be a tremendous opportunity to actually use that data to inform whether an alert fires or not. And as you can imagine, part of the reason that, there's so much information in the EHR that, why is the echo being ordered? That's really what you want to know. And just using the structured data in the EHR, it's actually probably really very difficult to figure out why is this ultrasound being ordered. Whereas like the clinician probably explained to the patient in the visit why the echo is being ordered, or you could surmise based on the patient's chart, all the information in the patient's chart. And so you can imagine a scenario in which if those types of things could be used to train the alerts on the appropriate times to fire, you could have an alert that maybe was being accepted 80 or 90% of the time because it was so accurate as to whether it was firing or not. And so I think that would be a potential use case for AI in these scenarios. Obviously, you'd have to then be worried about the inappropriate firing of the alerts from hallucinations and other things. And it's a bit more of a black box in that case as to why is the alert firing. But I think the potential to increase the accuracy of the alerts for the appropriate patients would be tremendous, I think, with that.
Yeah, that's great. So more targeted alert firing. Great. Dr. Lindquist, would you like to unmute and ask your question?
Thanks, Laura. Neil, Sam, very nice work, and it really shows the power of collaboration between clinicians and the ESU. A couple of minor questions. Neil, can you tell me a little bit about the likelihood of ordering the limited use in relation to the number of prior echoes? So in other words, people might not be, there may be some relationship between the number of prior echoes and the number of the likelihood of ordering the limited. And the other is, were there any instances of people ordering a full after they got the limited? So in other words, it gets you potentially an error rate of the trigger itself.
Yeah, those are great questions. So I definitely think there's a relationship between previous echo ordering and then ordering a limited echo. Most of the time, a limited echo is appropriate is as a follow-up of a known cardiovascular issue. Now, in this case, we elected not to include the presence of a prior echo as a triggering criterion, and that was partly based on the idea that patients may have had an echo while admitted to an outside hospital, and so that you wouldn't have that in the Stanford system. Or someone may have had a different type of imaging test, like an MRI, that showed an abnormality, and then you're getting the echo to follow up on the MRI. And so just the presence of an echo may not show you that. However, there's always this trade-off. You probably would increase the appropriateness of the alert if you trigger off of the existence of a prior echo, but then you're maybe limiting your population size. And so again, that gets back to this, like, the fidelity of making sure the alert's only firing in appropriate scenarios versus the population eligible for your alert and having a wider intake. And so I think there's a trade-off there, but it definitely would increase the accuracy, I think, if you had that as a prerequisite. As far as the error rate, I think that would be definitely something worth looking at and something we probably should go back and look at. One of the challenges is that what we had access to was not the charge of what was actually done by the echo lab, but just what the echo order was. And because the limited echo order gives the echo lab the option to convert to a full, we actually didn't know what happened on the end of. So all we know is what the clinician wanted or what the clinician ordered. So I think a whole separate analysis, which is probably worth doing at this point now that the alert has been deployed, is what actually happened when the patient got to the echo lab, what was charged by the echo lab, because you could see a scenario in which 50% of these limiteds are then being converted to full echoes on the end of the echo lab. And that obviously would be undoing any effect of the intervention upstream on what the actual clinician's ordering. So that's the downside of including that option, is you actually don't know what the echo lab does after the test is ordered. So this analysis was, I should caveat, was focused on what was being ordered by the clinician, not what was actually done by the echo lab.
Yeah.
Definitely something worth looking at.
You may need to do some finessing of your algorithm itself. The information that you're offering people, or guidance. Interesting.
And I think, Dr. Kolwani, your response then about what you looked at and what you didn't look at in terms of evaluation. So I have a question for Dr. Kling related to that. If you were going to do your evaluation again, I'm always a proponent of continuous improvement when it comes to our evaluation strategies, in terms of improving what we do next time. What's something you would have done differently if you were going to run it again? How would you modify your evaluation approach, if you could do this now?
Yes, thanks, Laura. Yeah, there are many things. We wish we would have had better access to physician level ordering data. We actually use existing reports to look at clinic level data. So we couldn't really do a deep dive on the variation in ordering between clinicians. So when I showed those bar charts, those were just based on signing the echocardiogram orders to clinics. So I wish we could have done a deeper dive on individual behavior and seen the range of that. And then, as Neil briefly mentioned, like, we got involved about a year into the implementation of the alert. And I think our qualitative interviews really revealed some great changes that the team made. And I wish we would have been involved a little earlier so we could have made those changes and helped the team make those changes to the alert for the primary care providers prior to a year and a half into the project.
Great. Dr. Kolwani, is there anything you would change in terms of evaluation?
Yeah, no, agree with Sam. I think that, when we did the rollout, I think there were definitely some key insights that emerged very quickly from the qualitative interviews, which I think we may have actually adjusted the intervention earlier. And so I think that was definitely one that made me appreciate, the value of doing those qualitative interviews. And then, yeah, I think that the other thing that was, can't really change it, but we would have loved to know what was the effect on total echoes. And this gets a little bit at Craig Lindquist's point about the, what was how many full echoes were happening. And one reason we did the proportion of echoes as opposed to the total number of echoes was that there was a dip in echo ordering associated with the COVID-19 pandemic that then recovered towards the end. And that actually made it very complicated to look at total volume as opposed to the ratio of the two tests. And so I think if we had not had that confounding from the COVID-19 pandemic, it would have been really nice to understand how this alert impacted the total number of echoes, because ideally what you would want to see is substitution of limited for full, as opposed to people ordering extra limited echoes in addition to also getting the full echoes, or then having to get the full echo anyway to really understand the effect. So I think that would have been a nice aspect of the analysis as well, if we'd been able to do that.
Okay, great. Well, that brings us to time. Thank you so much, Dr. Kolwani and Kling, for your work today. Really fabulous work, really interesting. We really appreciate your presentation. And thank you everybody for joining us today.